I'm going to go ahead and start the prevention panel. My name is Kelly Rulison. I'm going to be moderating our panel. We've got 4 great speakers here with us today. And just to give you a little bit of overview, each of us is going to do a brief introduction of ourselves. And then I have a few questions that I want to get us started, ask our panelists to chime in about. And then we'll wrap up toward the end with questions. I'll keep an eye on questions in the chat, questions in the Q&A, and we'll have plenty of time for all of you to chime in with some questions for our panelists. So to get started, like I said, my name is Kelly Rulison, and I'm a faculty member in Human Development and Family Studies at Penn State, and I'm part of the Consortium to combat substance use and addiction. My research really focuses on how program developers can build more effective interventions and then promote the diffusion of intervention effects to reach those who didn't participate. So usually with our interventions, we target a subset of people who are most at risk or are having problems, but then we can have an effect on those around them, their friends, their family members who didn't actually participate in the interventions. So most of my work focuses on substance use and other health-related behaviors. So I focus on the role that peers play in shaping delinquency and suicide behaviors and sexual violence. And I focus mainly during adolescence and emerging adulthood. This is a time when a lot of health risk behaviors emerge, but also when there's a lot of changes in the social context that can help lead to a lot of substance use or other health risk behaviors. But it's also an important time when peers can play a really positive role as well. And that's why I want to look at how the role that peer social networks can play in promoting the diffusion of intervention effects to have that broader effect. And finally, the other area of work that I focus on is trying to strengthen our current interventions so that we can create more effective and ideally optimized intervention programs. So that's just kind of briefly. I want to save more time for all of our panelists to introduce themselves. So why don't we start with Megan, if you want to take a few minutes to introduce yourself.
Sure. Thanks, Dr. Rulison. And good morning, everyone. My name is Megan Affrunti, and I'm the Director of Substance Use Disorders and Recovery at the Clinton Foundation. My background is in public health and social work, and our program works in communities and with community leaders across the country to raise awareness about addiction and overdose, to reduce the harmful stigma that surrounds these issues, and to increase access to life-saving resources such as naloxone and training like mental health first aid, which is essentially CPR for mental health and substance use disorders. We think about prevention broadly in our program, insofar as our efforts focus on primary prevention, early intervention, and overdose prevention. This is our 3rd year participating in this conference, and I'm really happy to be here and have enjoyed the conference so far and look forward to the remainder of the day. So thanks so much for inviting me to participate.
Thanks, Megan. Rina, would you like to introduce yourself?
Sure. Good morning, everybody. My name is Rina Eiden. I'm a professor of psychology and also a co-funded faculty for the Consortium for Substance Use and Addictions at Penn State. And I study mainly, I'm a developmental psychologist by training, and I study risk and resilience processes in children of substance using parents and substance using families, beginning in the prenatal period. So I'm interested in prenatal substance exposure and its effects on children's developmental trajectories, and ending in late adolescence, so sort of long-term cohort studies. And then applying what we learned from these studies examining risk and protective factors to early childhood prevention, family-based prevention mostly, and some work on substance use treatment. And I've studied families where the non-pregnant partner, mostly fathers, have an alcohol use disorder, families where mothers were using cocaine and other substances in pregnancy, and families where of cohorts of pregnant women using both tobacco and cannabis in pregnancy. So it is also my pleasure to be here, and thank you, Kelly, for inviting.
Thanks, Rina. Darigg, would you like to go next?
Okay, sure. Good morning, everyone. Thank you for having me. My name is Dr. Darigg Brown. I am a manager in the Substance Use Prevention Evaluation and Research Program at RTI International. RTI is based in the Research Triangle area, Raleigh-Durham, North Carolina, although I am based in the state of Georgia. And we are a fairly large research organization with quite an international presence. We conduct rigorous scientific research really to improve the practice of science and public health to impact the human condition. I'm a behavioral scientist by training, and my program sits in the Community Health Research Division of RTI. Our program really focuses on risk and protective factors of substance use, as others have said, and conducting effective, rigorous evaluations to really highlight and enhance how programs and prevention efforts can sort of move the needle in terms of reducing substance use among community-based populations. My focus is mostly with youth and on youth development when it comes to substance use and how that relates to other outcomes such as academic achievement and other related conditions such as sexually transmitted diseases, violence, mental health, and trauma. RTI has been around for some 60 years, I think, and we work very closely with a number of associates, partners, clients, and communities at the local level, state level, federal level, of course. And our work really spans the gamut in terms of prevention across various content areas. Proud Penn State alumnus, graduated from the College of Health and Human Development. So this is my first time participating. I think RTI's first time participating in the CSUA conference. So very glad to be here.
And our last panelist is joining us on the phone today, I think. Jeffrey, are you there? You're muted. I don't know if you can hear us or if you can unmute yourself, Jeffrey. I know he was having some computer problems, and that's why he had to join us by phone. But so why don't we go ahead and hopefully maybe he'll be able to join us in a few minutes. But why don't we get started with some questions that I have for the panelists. For this, I'm gonna throw out a handful of questions. I'll get started, and then feel free, any of you, to jump in. So the first question I had is, in moving from basic research to prevention, are there community-related steps that each of you have taken or that you would recommend that other people take?
So I can jump in if that's okay. So I would say, that's, for 20 some years doing longitudinal studies with families who had substance use disorders. That was my ultimate sort of goal, right? Is to go from these longitudinal studies, cohort studies, to then applying what we learned to prevention research, and moving from sort of basic science to prevention. Program has been, community engagement has been really important and helpful in that process. So we did to give you an example, we did a longitudinal study that lasted for 20 some years of community recruited families with infants where a father had an alcohol use disorder. And we assess families at multiple time points from infancy to late adolescence, and then try to apply what we learned into our prevention program. And so community, when we went to do this, we presented sort of our idea, what we learned and where we wanted to go to a lot of different community organizations to gauge interest and to get their feedback and advice about how to sort of move from this basic science to prevention, what their experience has been and what their advice would be for us. And whether this was something that they thought was important to do in the community. And so these groups included prenatal and perinatal networks who work with pregnant women, with OBGYN providers, with social workers, nurses, university CTSI groups, community groups who work with fathers or led fathering workshops, nurse family partnerships, WIC staff, and church leaders who counsel families and so forth. We presented our ideas, we solicited feedback about how to do outreach and how to talk with families about the program, since these would be families who hadn't identified themselves as having a substance use disorder for the most part. And then things they thought that we should consider as we thought about critical intervention components. We also did a needs or feasibility assessment in the clinics that we wanted to recruit from, and asked our community groups if there were questions that they were curious about or they thought would be helpful to their work. And we included these questions in our assessment, which we conducted over the summer. And we had open-ended questions as well as sort of targeted questions regarding eligibility. And so we had a lot of we solicited a lot of feedback from our potential participants during this needs assessment, and then created sort of infographics in electronic and print format so that we could give the information back to the community groups who we had engaged with in the beginning. And then because of these initial sort of extensive conversations, as we wrote the grant application to get funding, it became clear, which community groups were really interested, engaged, and who we should partner with, who would be interested in being part of a community advisory board in our grant application. And as we have now moved from getting the grant to then recruitment and retention of families, the community advisory board that we have, we have once every couple month meetings to give them a sort of a report of where we are, where we're going, any advice they have, any issues they see emerging that we should think about, etc. So community engagement, I would say, has been really essential as we move from this basic science to prevention program.
Thanks, Rina. Megan or Darigg, do you have anything to add in this area about your experiences or recommendations?
I think I'll echo some of what Rina said when and really focus on community engagement being so critical. One of our key programs that I think I'll talk about more later involves working with faith leaders from across faith traditions and building their capacity to advance prevention, treatment, and recovery in their communities, and to really be a supportive member of the community for individuals and families who are impacted by substance use disorders. And when our team is invited to enter a new community with this program, we do also conduct a needs assessment to supplement any data, publicly available data, and other types of data that are available to get a better understanding really of the types of substances being used and the groups that are most affected in the community by these issues, to collect data on risk and protective factors related to substance use, and also to understand the resources that already exist in communities for prevention, treatment, and recovery, so that we can do our best to link faith leaders and their communities to these resources without duplicating efforts. really. So with this information, we've really been better able to create and tailor programs to the community's context and implement interventions that are informed by the best available evidence. So just highlighting that community engagement has been really key for us.
And I would echo exactly what Megan and Rina have said in terms of involving and engaging community early and often. It's quite necessary when you're talking about really wanting to make sort of a sustainable impact on the outcomes that you see in communities, and really instilling that sense of ownership within communities to sort of drive change themselves. The research that we do, much of the research we do is evaluation research. So oftentimes our team at RTI is not, we're not the folks who are in the community on the ground, developing the program, sort of implementing the program, talking to those community members and coalitions. We're sort of looking in from the outside and looking at the entire process, all of the assets and resources that have gone into the development and implementation of these programs to determine how it's been effective, how well an intervention has been working, what some of the challenges are, and sort of driving recommendations for future prevention planning. So evaluation, of course, is a big piece that sort of transcends an entire sort of programmatic prevention effort, and that's where we come in, and we've seen and heard from local prevention providers and other stakeholders and community members who are on the ground how big of a role evaluation results data play in driving the planning for future prevention efforts.
Really fascinating answers from all of you. I appreciate all the different perspectives that everybody has. So another question that I had kind of builds on what Megan was talking about. But community collaboration is really key to prevention, and every sector has a role to play, as she started talking about. So what role do you guys think that faith leaders and other community leaders can play in ending the addiction and overdose crisis?
I'll jump in on this one and just say that I think we all know that the magnitude of the overdose crisis really requires an all hands on deck approach and the most innovative solutions that we can think of. When my team was building out our program, our community-based program several years ago, we thought about who are the most influential people in communities? Who do people go to with their concerns? Who do they listen to and who do they trust? And who can spread accurate messages about prevention, treatment, and recovery, and really combat the stigma that keeps addiction in the shadows? And we landed on faith leaders. We know that, we believe that faith leaders have a really critical role when it comes to the addiction and overdose crisis. However, they don't often have the knowledge or the skills or the confidence to engage in the work, because most don't learn about these issues in seminary, and they aren't necessarily equipped to work in this area. So in 2018, to really fill that gap, we created the Empowering Faith Leaders program, which works to equip faith leaders from all across faith traditions with the knowledge, the skills, the resources, and the confidence to address addiction using compassionate and evidence-based or evidence-informed approaches. And thus far, we've launched our program in 7 different communities, and we've worked with over 140 different faith leaders. And the faith leaders who participate in our program are mobilized really to take concrete steps in their communities. And our data shows that they successfully educate their communities, that they reduce stigma, and that they increase access to information and resources after they've been through our program. And as Darigg talked about, evaluation, we've been really lucky to have an evaluator, an external evaluator, assess our work over the past several years. And it has not only helped us improve our program, but it has helped us understand the impact of our work. We're currently facilitating our program in Savannah, Georgia, and we plan to replicate our program throughout the state and then the country to continue making this impact, which we think is unique and really important. Thank you.
Yeah, and to that, I would add, faith leaders are definitely important, often critical to prevention efforts and the communication around certain issues, how they impact and affect communities, and sort of gathering consensus or response around what it means to people in the community who are affected. Faith leaders, as Megan mentioned, are very often sort of trusted leaders and pillars in the community. They tend to understand some of the cultural nuances that inform the different ways of knowing. And they're usually very established in the community. They've been there a while. People know them, and they just tend to have a way with communicating and sort of getting to the root of issues and how people are feeling and tapping into those sort of emotional components. But despite all that, I think faith leaders can sometimes be difficult to bring into the fold when it comes to talking about timely issues, issues that may seem taboo in some circles, or things that would otherwise shine a negative light on the community. However, faith leaders can bring a very unique perspective on substance use and addiction and overdose in particular. Again, because they many times provide counsel to individuals and families, and sort of use the biblical or religious perspective in teaching and helping people sort of come to terms with issues that are impacting them. Faith leaders lead very tight-knit communities, I think. So, if there are issues that are in, whatever's impacting one impacts them all, correct? So they see their congregations and their membership as sort of a flock, and a flock that is to be protected. So I think it oftentimes goes without saying that faith leaders will definitely have a vested interest in helping in any way they can, even if they don't have technical skills or research knowledge, as Megan said, to necessarily jump in and address an issue. Faith leaders can also provide safe space for community members to gather, and sometimes they can provide resources in terms of facilities and in other ways to sort of develop and implement these targeted programs. Their charitable efforts, and I guess their mission often speaks to how they seek to lead people out of darkness toward a more hopeful future. And I think that's what we all strive for in the prevention field. And faith leaders really have a unique perspective on that, and some unique opportunities, I think, to impact change in that way.
Really helpful perspectives. I'm kind of curious, building on this, are there other strategies or other ways that you guys have gone about identifying other community members that are really important to prevention efforts beyond engaging the faith leaders, which are so central as we've talked about?
Again, coming at this as an evaluator, we have certainly heard from prevention providers and other local officials, ways that they have tried to tap into other resources and establish other partnerships across various sectors of the community. There's sort of your typical types of partners, again, a faith-based community, the business community, perhaps, educators, local school systems, school boards, law enforcement. We hear about those types of partners quite often. But I think it's worth pushing sometimes to get people to think outside the box, think about some of those non-traditional types of partners. These, again, could be people who really have a good sense of not just what's going on, but how people are talking about, issues of substance use, how it's really impacting families and communities. These could be, local barbers and hairstylists. These could be, funeral home directors who have talked to and consoled people who've had family members who have succumbed to substance use. Other types of industries and local government entities that tend to play a role, perhaps a tangential role, in providing funding and resources to substance use efforts. Chamber of Commerce, even. We've heard about lots of different types of community partnerships that have been established and folks who've been engaged in these efforts. Folks, again, who just really have a vested interest, who've been around a long time, who retired teachers, perhaps, who have seen several cohorts of students over decades, come through their classrooms, and they saw these folks as children, and now they see them as adults, perhaps with families, and are they encountering some of the same struggles that their parents went through, 20, 30 years ago? How is living in this community impacting their lives, and what are some of the opportunities that they see moving forward? It's been really interesting to see how people have pushed to establish these other types of non-traditional partnerships in their communities, and to see that group coalesce around a particular issue like substance use in their own communities, and then leverage resources, turning over every single rock possible to come up with resources to address an issue, particularly in communities that may be less resourced. So I think that's very important, and I think we've seen a lot of success in that regard, certainly for effective implementation and sustainability of those efforts.
I would just add to what Megan and Darigg, what you said, as one of the challenges that we faced as we were getting in the field was the pandemic, and having built a lot of community engagement and learned about, Megan, you said something about resources in the community that already existed. That was an important aspect for us as well. Now moving to having to pivot to doing everything virtually, community engagement has taken a different meaning for us, since that happened. So our community has broadened tremendously, and trying to figure out how to engage like entire states has been, the one good thing has been we're not localized anymore. But the one challenge has been how to build that engagement in a wider geographic area, and how to identify sort of resources that are available within communities that people could take advantage of if they didn't have the resources themselves to engage in a virtual prevention program that was delivered virtually, where evaluation was occurring virtually, and then how to do recruitment in that space. So the meaning of community has really sort of changed for us as a result of the pandemic.
Really important points here. And I am going to ask one more question, but I wanted to encourage everybody else who's listening. We are going to have some time, and we've got, like I said, some great panelists with a lot of different backgrounds and perspectives. So I encourage you to type your questions into the chat or the Q&A, and I'll be able to read them to our panelists after. Maybe I'll ask one more question to get their opinions on. So one thing that I'm particularly interested in is really how can prevention advocates work for sustaining our efforts. So we talked so much about how we're getting communities involved, and want to think about the long term, the sustaining these efforts beyond just relying on grant funding, which is, for those of us in academia is often our first kind of go-to. But what kind of strategies or what recommendations do you guys have for trying to build in sustainability, thinking about it right from the very beginning?
I'll jump in here, and I'll say that I lead a couple of evaluation efforts. These have been long-running, sort of multi-year cross-site evaluations at the state level. One of which is in Georgia, Megan. So including some folks in the Savannah area, and over time, the state has really pushed local prevention providers to do just what you're talking about, Kelly. Really think about sustainability, how their program will look going forward, and putting a plan in place. Getting something in writing, having some sort of idea of what the prevention provider organization and the community would like to see from this type of intervention effort moving forward. And in thinking about sustainability, it's not just about how will we continue to fund this effort, where will we get money from. A lot of communities don't have the resources or necessarily the know-how to tap into big, huge federal grant funding opportunities, but they can think about sustainability as more of an enterprise. Again, establishing that ownership among community members, among strategic partners, and figure out a way to gather interested parties and ensure that everyone has a specific role in maintaining the momentum of a particular strategy, and continuing to move that forward through this sense of ownership. Again, it's not just about maintaining the program itself, but also maintaining the outcomes. Every program starts with a particular set of anticipated outcomes. What do you want to see? What's the purpose of this? What's the overarching goal of this effort? And you want to not just implement something for the sake of implementing it, but you want to continue to see those outcomes, and you want to continue to see community members flourish. So that's how sort of the state of Georgia has been encouraging local providers to think about sustainability, and come up with ways each year, to improve upon that sustainability plan based on what was done over the past year. What are some things that we could implement permanently to help keep this train going forward. Funding is always an issue. That's sort of always top of mind for people. But there are other things that could be just as important as funding to help sustain prevention efforts.
I'll just add that when we created our Empowering Faith Leaders program, we really had sustainability in mind through our capacity building model. So we sort of think of it as maybe a bit of a train the trainer approach, where we build a capacity of faith leaders to do this work in communities, and in turn we hope that they are sharing the information with their communities, right? Whether it's information about the science of addiction, about naloxone, about treatment and recovery resources in their communities, about how to safely store and dispose of prescription drugs, whatever it is. And when faith leaders join our program, it's with the understanding that they're sort of going to play a role in disseminating the information and resources that we share. And in that way, I think the approach leads to community sustainability. The other component of our program is action. So all of the faith leaders who participate in our program are expected to complete what we call a community-based engagement project. So during the duration of our program, which lasts anywhere between 9 to 12 months, there is this cohort of faith leaders working through it together, and they are planning and eventually executing a project that is going to educate their communities, it's going to reduce stigma, and then it's going to distribute resources. So I think mobilizing community members to act, I think really kind of leads to sustainability and leads to important messages and resources, staying present in communities. And I feel that when certain community actors are mobilized around a certain topic, especially this one, where people are seeing their congregants, their friends, their family members dying from overdose and struggling with addiction, they continue the work, and we're always amazed when years after we end a program, we hear from a faith leader with an update about what they're doing in their community to continue the work. And that's when we know we've made a difference and that the work is being sustained in community.
One thing I wanted to add is that sustainability can also, we could also keep sustainability in mind when we're choosing our programs, right? So part of the reason we chose this, so we chose screening and brief intervention as one component of our addressing parental disorder in our families and delivered in a motivational interviewing format. And part of the reason we chose that is because we thought it could be implemented by essentially anyone with not a lot of extensive training, and could be implemented across a lot of sort of platforms and within a lot of different organizations, and also it was really accessible in terms of trying to promote sustainability. So I'm, thinking that sustainability is something that we could all keep in mind from the very beginning as we're designing prevention.
These are all really great suggestions and things to consider at all the different points. And Megan, it's encouraging to hear you're talking about people coming back and saying that they're still to know that you're still making a difference and that people are continuing to engage in the program. So we've had some great questions in the question and answer, and one of them actually builds on this conversation on sustainability right now. So I want to start with that one. Sharon Whitebread wanted to know, so what are your thoughts or suggestions on how to build relationship with law enforcement community regarding their extreme resistance to harm reduction programs? So things like syringe exchange and now Narcan possession, which is, she mentioned is the climate in Northeast Pennsylvania. I don't know if any of you have any suggestions about working with law enforcement specifically around this topic, or others who are resistant. We often see that with harm reduction strategies or programs.
I do not have a specific suggestion for working with law enforcement in the northeastern Pennsylvania area, but I do know that from a community perspective, law enforcement is sometimes law enforcement is either all in or they're completely resistant to participating in any type of prevention effort, not because they don't believe in prevention as a way forward, or that they don't believe that something needs to be done to address an issue. It could be that they are just simply overstretched and have other priorities, especially in some of our smaller communities that we work with, where their force may be just a few officers, and they're required to cover a county of huge geographic mass. Also, a lot of law enforcement officials and agencies feel that they don't necessarily have the support from the community or from other sort of higher level policy and decision makers to implement some of the things that they are being asked to implement. In this case, these types of harm reduction programs, implementing and planning for syringe exchange type programs, they really require partnerships with other agencies, with other leaders in the community. Again, because you're asking law enforcement officials to sort of take time away from their beat or from their law enforcement duties to do these types of programs. I think that the relationship between law enforcement officials is probably very tight, and they don't want to do anything that could potentially again shine a negative light on what they're doing, or sort of get in each other's way. But I think that additional resources have to be provided to law enforcement if they are going to be expected to play a key role in these types of harm reduction efforts. That would be my thought. Also, we've known that prevention providers have often gone to law enforcement agencies to request data, up-to-date data on substance use and things like Narcan possession and harm reduction programs and the effectiveness of those programs. Again, that's something that I think everyone has some challenge with at some point or other, but especially with law enforcement where data may not always be captured in a timely manner or accurately. Sometimes it can be very hard to provide up-to-date data on what's going on in a timely manner. Again, resources are needed, human capacity. It all comes back to that, and but we continue to try.
I'll just quickly add that one of the ways that we've been able to engage local law enforcement in these conversations has been through prescription drug take-back events. So some of you may be familiar with them. They occur twice every year. The DEA hosts a national prescription drug take-back event. And we have been able to have our faith leaders and other community members that we work with serve as host sites for these take-back events, where they'll actually be the ones educating their communities about safe storage and disposal, promoting the event, and inviting their community to come, usually on a Saturday morning and early afternoon, to drop off their prescription drugs. In the states that we've worked in, all of the sites require that a law enforcement official is present because they're, our drugs being handled and deposited at a local location, at one location, and in order to dispose of the drugs at the end of the day. So we've really used these opportunities to chat with law enforcement about what we're seeing in communities and really talk about, like, hey, are you carrying Narcan? What do you like? If you're not, why not? Really understand their perspectives and try to, share some insight and education on what we see. And then I think involving them in these types of projects really brings them in, right, to the importance of these efforts and prevention and kind of the community level work around these areas. So I think we just think of creative ways to engage them and take opportunities to kind of educate and hear concerns.
Yeah, I think that's such a great point, and kind of builds on that aspect of really needing to have those community relationships to try to tackle some of these problems. So I wanted to ask another question here that Janet Welsh asked. that said that often, we encounter influential stakeholders in our communities who, they promote different programs or practices that we would not recommend due to the lack of evidence or possibility that some of these programs that the influential stakeholders are recommending can even have harmful effects. Do you guys have any suggestions about how to handle those situations when you're dealing with community members who might have different perspectives like that?
Well, sort of break the silence here. I will admit that's a tough one, because more often than not, we have seen where community members, if they're receptive, want to hear what sort of scientific research experts are presenting. Okay, what do you have to say about the issue that's going on in the community? What kind of response do you think it is? And then hopefully folks can convene and discuss and talk about a sufficient way forward. I guess this piece about recommending programs or things that could cause harm, that really warrants further discussion. I understand how the data and the evidence could indicate that a particular strategy could be harmful or is not within the realm of recommendation because of a lack of evidence. But I think it's really worth discussing with those influential stakeholders why they firmly believe that this is something that will benefit the community or something that will resonate with the community. There could be some underlying cultural nuance sort of embedded in their reasoning and rationale for wanting to move forward with a particular practice or a particular strategy. It certainly doesn't behoove us as researchers to put it down completely without having a full understanding of why that particular strategy might be appropriate to that stakeholder. I also think it's worth presenting the evidence or lack thereof for a particular strategy and having a conversation to sort of reconcile the two viewpoints, and then getting the opinions and perspectives of other stakeholders. It's while these stakeholders may be influential, there are other people and other people who will be impacted by these decisions as well. So I think it's worth getting a multitude of perspectives and viewpoints.
I think that's a really great point. I'm kind of aware of the time. I'm wanting to shift to the next panel, but I wanted to just read a couple comments that kind of build on what you were saying, Darigg, and the theme across many of what you guys were saying, just about the importance of involving the stakeholders. And there's a couple comments here. Lauren Wicks pointed out that some of the most important voices to include from the community in terms of advisories and engagement aimed at informing our program development should really be the people who are living in recovery. And as they define recovery, as well as people who are using drugs and their family members from the population. So casting kind of a wide net in terms of, we talked about different community leaders who to include to get our programs out there, but also really influential stakeholders are those who are going to be directly affected. And then Janet also mentioned back to our last question, but it kind of fits here as well, that in Prosper Plus that they've had really good success engaging law enforcement around the drug take back, and just that really kind of underscores just how important those local relationships are for making all of what we're doing work. And I know that was kind of a theme across what many of you mentioned as you were talking as well. So I'm going to leave that as our kind of our ending point here as we switch to the treatment panel. And for that one, Sarah Kawasaki is going to be moderating that one. So thanks for letting us, having great questions for us. And thanks to our panelists for great discussion and really giving us a lot to think about, and for all the work that you guys are doing.
Thank you very much, Kelly.
Thanks.